Myself and Dr. Calvi developed the initial draft of the document. The commentary was then reviewed by MJ Stowe and Dr. Nirvana Morgan. All authors subsequently reviewed their sections and the overall document. All authors identified their own local documents or confirmed the lack of their existence. This research was kindly funded by the South African Medical Research Council grant held by Tanya Calvi. And we'd also like to acknowledge Necpam and its members, and particularly we'd also like to acknowledge Dr. Dmitry Krupchenko, who provided feedback for this commentary. We reached out to our membership and asked members to provide us with an overview of guidance documents, policies, standard operating procedures, and other pertinent documents related to managing substance use and behavioral addictions in the context of the pandemic. We then charted and mapped these papers, and we co-authored a paper summarizing these results, which I'll outline some of the summary results in the next few slides. I would very much encourage you to read our paper, because there's a fantastic table within the paper where it outlines the various documents and the different components, and it provides that for all countries. There are a number of limitations to the paper, namely being that we lack representation from country-level documents from a wide range of countries, but particularly from regions such as the Americas, Eastern Europe, the Middle East, Africa, and other regions around the globe. Several of the documents that we surveyed focused on COVID mitigation practices. Some documents discuss PPE, so as for example Indonesian, Italian, and Nepalese documents. Several documents discuss risk assessment and mitigation practices, for example Malaysian, Moroccan, New Zealand, and Australian documents. Indian, Thai, and Malaysian documents discuss the reduced admission of patients. Several documents discussed how to implement physical distancing procedures, for example Indian, Indonesian, and Japanese documents. Standard operating procedures were also developed for isolation units in Ireland. It's worth mentioning at this point, while I haven't provided references in these slides, if you read the paper itself, which we can provide a link for, there's a good overview table that is instructive and gives you a brief overview of all the different documents that we surveyed. Another thing that featured in many of the documents were a changing of trends. So, for example, Indian and Thai documents address substance withdrawal, with the Thai document outlining strategies for the management of alcohol withdrawal that may have occurred due to local restrictions on alcohol sales in response to the pandemic. Japanese authorities warned of the potential increase in the use of the internet, gambling, gaming, and the higher prevalence of drinking at home during the COVID-19 pandemic. Worth mentioning here that the Japanese documents were somewhat unique, as many of the other documents did not discuss this in much detail. What also became apparent is that many of the documents advocated for change of treatment modalities, some of them fairly radical. Several documents discuss the use of telemedicine. For example, French, Indian, Italian, Irish, Japanese, Malaysian, New Zealand, and Thai documents. French, Japanese, and Irish documents discuss the expedited access to opiate agonist maintenance treatment and the increased take-home doses of OMT was featured in many documents. For example, the Irish, the Indian, the Indonesian, the Italian, the Japanese, the Malaysian, the Moroccan, the Nepalese, and the New Zealand documents. And there was also a document that discussed buprenorphine and naloxone takeaway doses in a hospital context. An interesting other example was in one Irish document. It advocated for the prescription of naloxone for all new OMT patients, which were already receiving expedited access, and it also increased takeaway doses. And it also discussed a change in the naloxone administration procedure, whereby instead of nasal naloxone, which was just started being piloted, to use intramuscular injection and chest compressions only, unless you had specialized equipment during overdose interventions. A range of practices have been suggested at the country level to deal with the challenges brought on by the ongoing pandemic. These include those around mitigating the spread of the coronavirus, managing the risk associated with lockdown policies, and changing trends in substance use and addictive behaviours. In order to limit the spread of COVID-19, guidance has been drawn up to limit in-person meetings, physical support meetings, and contact time with physicians. Guidance suggests that this be operationalised through shifting services online, increased availability of takeaway doses of OMT, increased duration of OMT, and increased availability of naloxone and injecting equipment allocations. Protocols have also been drawn up for the operation for outreach services for patients in isolation. I just want to re-emphasize that there are several negative effects of the pandemic. These include risks of substance withdrawal due to alcohol restriction or lower access on the street, access to service issues which may have reduced their patient load, or due to physical restrictions which may limit people's access to the services, and potential changes in trends related to gambling, gaming, internet use, and other substance use. There are a few ways to meet these challenges. These include expedited access to OMT, increased access to takeaway doses, increased availability of online-based self-help groups and other services, service adaptations for people who use non-opioid drugs and are engaged in addictive behaviours such as gambling and gaming, which were not addressed by many of the documents. And I guess as an overview, few documents explicitly discuss the increased availability of harm reduction supplies and service adaptations for people who use non-opioid drugs and are engaged in addictive behaviours such as gambling, gaming, and internet use continue to be neglected by most documents. The combination of a reduction in the availability of services, increased reliance on telemedicine, physical distancing protocols, and travel restrictions may exacerbate underlying health inequities in terms of access to addiction services. This seems to disproportionately affect the most marginalised and socioeconomically disadvantaged patients who may lack access to internet-enabled devices, sufficient internet, the private spaces to engage in telemedicine, and means of transport to services which may already be restricted. Future research should document emergency practices in additional regions and monitor and evaluate the implementation of country-level policies. Country-level documents may be useful as they may allow clinicians to adapt to a given local context. Such documents should consider best practices as they relate to issues surrounding a wide range of substances, addictive behaviours, harm reductions, and health inequities exacerbated by the pandemic and restrictions. I'm more than happy to answer any questions now and as part of the session, or if you email me on florian.scheibein@wit.ie or contact@necpam.com, and you can see the study there in front of you in psychiatry if you want to read it yourself. Responding to COVID-19 emerging practices in addiction medicine in 17 countries. Thank you very much for listening, and thank you to all the organisers.